Good morning and a warm welcome to all the dignitaries, esteemed speaker, participants, faculties, and students on the first class of day 10th of National Webinar Series on Redefining Nursing Practice, Focus on Adult Health and Surgical Care. Today marks the last day of the webinar series where we have two classes scheduled. And for the first class, I deem it great pleasure to introduce you all to our esteemed speaker of the day, Mrs. K. Jyotishri Ma'am. Ma'am is currently serving as Associate Professor cum Head of the Medical Surgical Nursing Department at Rama College of Nursing, Rama University, Kanpur, Uttar Pradesh. Ma'am possesses over 11 years of academic and clinical experience with prior faculty roles at Divya College of Nursing, Ayavaru Reddy College of Nursing, and Rathamma College of Nursing, affiliated with Dr. NTR University of Health Sciences, Andhra Pradesh. Her clinical service was rendered as a nursing officer at the Government General Hospital, Anantapuramu, Andhra Pradesh. She holds BSc Nursing from Medivin College of Nursing, Hyderabad, MSc Nursing with a specialization in Medical Surgical Nursing and Cardiothoracic Nursing from Narayana College of Nursing, Nellore. Currently pursuing a PhD in Nursing from Malvanchal University, Indore. Ma'am is a recipient of the Global Women Icon Award 2025 conferred by ICERT India and USA. She has presented scientific papers at numerous national and international conferences. Ma'am has over 15 research articles published in peer-reviewed journals. She is an active organizing member, resource person, and external examiner across academic events and institutions. She has contributed to books and book chapters and guided UG and PG nursing students in research. She is recognized for her commitment to academic leadership, clinical excellence, and advancing nursing education and practice. In this class, ma'am will be covering renal disorders. I welcome you, ma'am. Please have the virtual stage.
Yes, ma'am. Good morning. Am I audible, ma'am?
Yes, ma'am, you are audible.
Yes. Thank you for such a wonderful, introduction. Ma'am, first of all, I wish a very good morning to one and all who, joined virtually today. And I also extend my immense, greetings to the organizing committee and chief patron of the Samarpan institution. And I sincerely thank Dr. Deepthi, ma'am, because out of her busy schedule, she has allotted, I really feeling privileged to be part of this webinar series, ma'am. And out of our busy schedule, she has given me a comfortable schedule. So for that, I will be very grateful to the madam. So without further ado, I'll be jumping to the topic, ma'am.
Ma'am, are you sharing or am I sharing?
Sir, I'll share, sir. I'll share.
Okay.
Is it visible, sir?
Yes, ma'am. Kindly, yes, ma'am. It is visible now.
Right. Can I start my session?
Ma'am, you can start.
So today I am here to present the renal disorders, and I feel like it will be a very interesting and most of the students' favorite system. I feel so, and I'll be starting with minimal like a revision, which there I can be also assessing the previous knowledge of the students here. So where I'm starting with the urinary system of anatomy and physiology, like where the urinary system is also known as the renal system or urinary tract, as it consisting of the two kidneys, two ureters, bladder, and one urethra. And we all know that it will be urinary system is also like playing a major role in regulating the blood volume and blood pressure, which will be controlling the levels of electrolytes and metabolites, and thereby regulating the blood pH. And can I have an answer from the participants, from the students, especially like what will be the normal pH? Any participants?
Participants, answer the questions in the chat box.
Okay. So the urinary tract is the body's drainage system for the eventual removal of the urine, where the urine formation will be done. So I'll be jumping just like, because all the students already oriented for this. So I just want to don't go into deep discussions. I'll just skipping my slides. And there are several functions which is carried out by the urinary system, like removal of the waste products, mainly urea and uric acid, which will be there halting the occurrence of the metabolic acidosis and alkalosis. And also will be regulation of the electrolyte balances, such like sodium, potassium, and calcium. And regulation of the acid base in order to maintain the homeostasis, like a balance or equilibrium, and also controlling the blood volume and maintaining the blood pressure. And here I just given the brief introduction about the anatomy. And as you know already that there is a nephron, which is the structural and functional unit of the kidney, where the urine formation majorly will takes place. So it will be consisting of like, Bowman's capsule and so many other structures like, proximal convoluted tubule, loop of Henle, and distal convoluted tubule, thereof like major, whatever the functions are carried out through the these functions. And on an average, a healthy adult will be having a 0.8 to 1.5 million nephrons in each kidney. Okay, and I hope everyone already familiar with the structure of the nephron. I am not going to discuss here. And I just want to discuss here one thing like how the urine formation and what will be the GFR rate. Can I have an answer from the participants? What will be the normal GFR rate in a healthy adult? I just want participant to be active in the session so that it will boost up me also. So the nephron will be taking a simple filtration. So that which we are calling like a filtrate. Thereafter, it will be going through many of the changes. Like again, there will be a selective filtration, selective reabsorption also will be taken place, and excretion will be taken place. There, it will be forming like a urine, which will be out. So when you coming to the GFR, like the volume of the filtered which will be formed by the both kidneys per a minute is called as a GFR, that is glomerular filtration rate. So here approximately on an average, you can see what in the men you can see like 125 ml per minute will be the filtrate, not like urine production. This filtrate again will be going further, so many changes because there will be like a so many pre-tubular or paratubular functions will be there where as I told you earlier, where the reabsorption will take place again. Many of the electrolytes again has been taken place like a selective absorption, and thereafter it will be forming like a urine. So here you can see after all these functions, you may consider that on an average 1 ml of urine per minute will be the average urine production. You can consider it as a normal. Sir, am I clear?
Yes, ma'am.
Okay. And then micturition. Micturition means like, we very oftenly use micturition for the urination or voiding. So it is like a voiding of the urine. And here I just want to mention one thing like urinary incontinence, where the bladder is unable to, the loss of bladder control or unintentional, passing of the urine, where the people will be having the unintentional urine passage. So it will be of like, 4 types, where urgency, incontinence, stress incontinence, or functional incontinence, and also overflow incontinence. So it will be differs a little bit, and we can provide some behavioral therapies or some medications and even nerve stimulation therapies so that we can control the urinary incontinence. And research studies are suggesting that following the Kegel exercises are showing more benefits in controlling the urinary incontinence. So let me jump into then here I'm just discuss about the, urine characteristics, and the color of the urine will be like pale yellow to deep amber, and odor will be like, sometimes it is aromatic or odorless, and volume will be like 750 to 2000 ml per 24 hours on a healthy adult, and pH will be like 4.5 to 8.0. Like you can consider it like some minimal alkaline or basic in nature. So the specific gravity ranges from 1.003 to 1.032. So you can see here like how the hydrated healthy adult urine looks and how dehydrated adult urine looks. So here I just want to quote some terminologies like where the volume of the urine will be like 1 to 2 liters per day. It will be the normal, where you can see like polyuria, oliguria, and anuria, where you can see the polyuria like, less than like, more than 2.5 liters per day. So we can see this one in the diabetes mellitus and other conditions like diabetes insipidus, and those who are consuming the excessive caffeine or alcohol, any sort of kidney diseases, or who will be taking, prolonged medications, certain drugs such as like diuretics, and people who are suffering with the sickle cell anemia and excessive water intake will also lead to the polyuria. Where coming to the oliguria, like it will be lesser than the normal. Like if we take the normal, it is like 1 to 2 liters per day. Where oliguria, like 300 to 500 ml per day, you can consider it is like a oliguria, where the people will be dehydrated and blood loss will be there, diarrhea. In those conditions, in these conditions, you can see a person will be experiencing with the oliguria, like a cardiogenic shock or kidney disease or enlarged prostate, which is also known as the BPH. And anuria, if the person is experiencing below like 50 ml per day, then it is considered, you can consider it as like a anuria. So where you can see this condition means like in a kidney failure, any obstructions such as kidney stones or tumors or enlarged prostate. This is like a brief view where you can consider what is the normal and polyuria, oliguria, and the anuria. So the mechanism which is regulating the kidney function is like, renin, angiotensin, aldosterone system, where we specifically needed antidiuretic hormone in regulating the kidney function. So far, I just have a brief introduction about all the things. So I'm jumping into the main disease conditions now. Like I'll be starting with the urinary tract infection. So it is the most common, and you may see most of the females will be suffering with the urinary tract infections very oftenly. So what is a urinary tract infection? Like it is a bacterial infection in the part of the urinary tract where it affects the lower urinary tract. And here I just want to mention, until the UTI is affecting the lower urinary tract, you can able to control and you can able to treat. Once it spread to the upper urinary tract, then it will be turning into a complication. So we have to be very careful when we are treating with the UTI. So then which will be affecting, like it is also known as the simple cystitis, like a bladder infection. And when it spread or affects the upper urinary tract, then it will be known as a pyelonephritis. So where it will be like you can sometimes consider like life-threatening condition until if you are not managing effectively. Then if you see the incidence, the females are more prone to get this UTI when compared to the males. And in the vulnerable population, you can consider older people is also having the high risk for developing this type of urinary tract infections. So when coming to the definition, it is like an infection which is involving all the structures of the kidney, like ureter, bladder, and the urethra. So what will be causing the UTI means, like most of the cases, 80% of the cases of the UTI will be caused by the E. coli, whereas even other organisms which are leading to the UTI includes like Enterococcus, Klebsiella, Enterobacter, Proteus, Pseudomonas, Staphylococcus, and Candida albicans. And here we can see there are several classifications, based on their clinical presentations, or you can see different types of the UTIs, like asymptomatic bacteriuria, acute cystitis, acute pyelonephritis, acute urethritis, acute prostatitis. I hope by seeing, by name itself, it is indicating like asymptomatic. You can consider like here, a significant number of urine will be there, bacteria will be there in the urine, but patient will not, expertise, or he will not show any symptoms like, such as burning during the urination or the frequent urination. So in this condition, it is very hard to identify, so that the treatment will be delayed. Then coming to the acute cystitis, indicates like which is involving the bladder here. The infection will be involving the bladder. Acute pyelonephritis, as I told, like when the urinary tract infection will be spreading towards the upper tract. So it implies like it will, like when it spread to the renal parenchyma and collecting system, it is called like a acute pyelonephritis. Then urethritis means like inflammation of the urethra, and prostatitis means like a bacterial infection of the prostate gland. So here you can see UTI can include all of the structures of the kidney. It is not confined only to the urethra and ureter. It may also spread to the upper portion of the kidney. So when it is complicated, as I told you, until it is not spreading to the upper tract, it will be, you can manage, it can be manageable. Where it is spreading to the upper tract, and especially like persons with the diabetes mellitus and those who are pregnant or males and who is having immunocompromised patients, it will be very complicated to manage this thing. Then coming to the predisposing factors, which are predisposing to occurrence of the UTI, like most of the factors which will be increasing the urinary stasis, like accumulation of the urine. So why the accumulation of the urine will take place? Most probably because of any obstruction. So that obstruction will be again like categorized like intrinsic obstruction or extrinsic obstruction. So what is intrinsic? Intrinsic, like intrinsic matlab, like there may be a stone or tumor of urinary tract or urethral strictures, like unable to close, or otherwise there will be some pressure which is exerted by the stones. Whereas extrinsic obstruction, like it will be including like any tumors which is compressing the urinary tract. So thereby it will be obstructing the urine and it will be causing like, accumulation of the urine. There it will be causing to the bacterial multiplication of the growth. Then urinary retention, that is like including neurogenic bladder. So where there will be any deficiencies in the neurons, there will be no communication or malfunction or malcommunication between the bladder and the brain. So there you can also see this UTI. And renal impairment, any sort of renal impairment which will be including like any structural or functional. Coming to the foreign bodies, urinary tract calculi, like as I already mentioned, so urinary stones also will be, and the most frequent cause for the UTI, and which is called like catheterization, like indwelling external condom catheter or any type of urethral stents or intermittent catheterization. You might be seeing in a clinical setup also, like most of the times people used to complain about the UTI after the catheterization or the removal of the catheterization. There we can see these incidences. Then and also we can see like due to some diagnostic procedures also it may be considered. So you can consider UTI like a iatrogenic also. So why we consider it as like iatrogenic? Because it also results from the instrumentation, like due to a part of diagnostic procedures where we can use like a cystoscopy or urodynamics. Then some anatomic factors also will be leading to the UTI, like where you can see some congenital defects, like any fistula forming or graft forming. So that like uretrovesico or urethrovesical fistulas, that will also be leading to the stagnation of the urine, where you can see the UTI. And also some other predisposing factors I have displayed here, like aging, and where the people are having like a immunocompromised status. And functional disorders such as like constipation, any voiding dysfunctions, and other factors which also includes like a pregnancy, hypoestrogenic state. So hypoestrogenic state, where the female can experience her like menopausal state, where if she will be having the low estrogen levels, which will be causing to lead this UTI. Then there may be other causes which includes the multiple sex partners and poor personal hygiene. So by discussing these predisposing factors, you may understand that why the UTI has been occurred, and you can also focus. Instead of we are focusing on the treatment here, we can focus much on the patient education here, I feel. So when you coming to the, see what will be the pathophysiology of the UTI, if you see, most of the time, the urinary tract above the urethra is considered as like a sterile one. Okay, so what will be happening? So when any physiological defenses are happening, or so through that, whatever the formed urine will be traveling to the bladder, and it will be voiding. Okay, so where the growth of bacteria will be more and it will be reaching to the upper portion of the urinary tract, then only it will be causing the urinary tract infections. Then if you see the manifestations of UTI, the person will be strongly having the urge to urinate. There will be strong or persistent urge to urinate. And while urinating also, person will feel burning sensation, which we can call it like a dysuria. Then passing frequent small amounts of urine, and you can the person also will experience the urinary incontinence and the urine where it appears like a cloudy. And so okay, so the urine that appears red, bright pink, or cola colored, which will be a sign of blood in the urine. And person, you also can, on the objective data, you can also feel like a strong smelling urine. And if, especially in the women, they will be complaining about the pelvic pain or the pubic pain. That's the reason here, in this case, the pelvic or Kegel exercises will be more beneficial. Then coming to the assessment findings, like you can, as usually, we are going with the in detailed history collection and physical examination we'll be doing. On the physical examination, you may observe the pelvic pain, pubic pain, all those things. Then apart from that, you can also go for some urine tests like urine analysis, urine culture. So where you will be, cultivating the bacteria in a sterile zone, there you can find out which specific microorganism is causing or leading to the UTI. Then one more thing here I want to mention, like clean catch sample. What does it mean? Can anyone answer? Have you aware about this? Anyone from the participants? Okay, so clean catch sample is like name itself, it is indicating clean catch. That means we are, collecting the sample in a clean or sterile way. So how we ask the patient, we'll give the patient like, sterile container, and we'll ask the patient to, while voiding the urine, we'll ask him first, whatever, when he started the voiding of the urine, we'll ask him to void little amount of the urine in the toilet. Then later in the mid, it is also called as the midstream sample collection, because we are collecting the midstream of the urine. Okay, we are leaving like a first or last sample of the urine. So we will be asking him to void first urine, and in between middle of the urine, we asking him to collect in the container. When the half of the container is filled, then remaining urine will be, again, we'll ask him to void in the toilet. So that's why it is also otherwise called as the midstream urine collection. And apart from all these things, you can go for other investigations also, where we are going like some non-invasive imaging studies, which includes like ultrasound, X-ray, or voiding cystourethrogram, or intravenous pyelogram, in order to see any of the structural deformities also. And cystoscopy, if at all, if you are not finding any structural abnormalities, or then if you want to go further more investigations, you can also go for the CT in order to rule out the kidney stones or other obstructions. And blood cultures, if the symptoms are severe and if you are not treating and not manageable, then you can go for the blood culture, because the bacteria will be entering into the bloodstream, so which will be life-threatening condition. Then coming to the management of UTI, like there is as I told you, it includes pharmacological therapy, like where it includes the medication, but being a healthcare professionals, we should mostly focus on the health education. So here we give the, so here prevention is better than cure in the case of UTI. So where it is coming to the pharmacological therapy, so uncomplicated cases, like where until it doesn't spread to the upper urinary tract infection, you can go with the managing with the antibiotics, like which will be single dose of administration, which will be short course of duration, like 3 to 4 days of regimens, or the 7 to 10 days of regimens. Whereas if it is spreading, then you have to start with the another microbial therapy also. Here I just quoted some of the drugs, like which will be including in the pharmacological drugs, like cephalosporins or ampicillin, which will be aminoglycoside combinations, which is given for the 7 to 10 days for the treatment to be effective. Otherwise, you can go for even trimethoprim or sulfamethoxazole, or otherwise the most commonly used drug of choice for the treating UTI is like ciprofloxacin, which is known by everyone very commonly, and levofloxacin. And in certain cases, we also go with the nitrofurantoin, where it is, and some research study shows that it is also effective in the even breastfeeding mothers, which is showing the very like a mild side effects. Then in the long-term pharmacological therapy, for example, if there is any relapsing or recurrent of the UTI, then you can go for the long-term therapy of these same combinations of the doses. If the recurrence happens and the person is unable to treat this one, like after the complete microbial therapy, for example, if you have given 3 to 4 days or 7 to 10 days, again the recurrence happened, they can also go for the short-term course of the 3 to 4 days full dose of antimicrobial therapy again. So here coming to the patient education, which is playing a vital role in the prevention of the UTI. So you always suggest the people like how it occurs and what are all the precautions they can take so that they can prevent the urinary infection. Okay, and if you know, many of the staff nurses are those who are working in the clinical setup, they may have the chance to have a UTI. Why, you know? Anyone? I'm not getting any responses from the participants. Okay, so why it is happening? Because see, when they are occupied because of the overburdens or burnouts or duty hours, prolonged duty hours, what they will do? Many of the staff nurses, they will give the priority to the patient care, and they will be holding their urination. So this is the major cause which will be leading to the UTI. So do not delay urination when it is necessary. Okay, everyone might be experienced this one, and a high fluid intake is also essential. And you know already, like per day, you have to take adequate amount of the water in order to prevent all these type of infections. And you can also do like cleaning the urethral meatus, which is the opening of the urethra, like after the intercourse. So, and here drinking especially 250 to 500 ml of cranberry juices daily. Those who are having recurrence, incidents of the UTIs, they can prefer this one. If they are taking cranberry juices daily amount of like 250 to 500 ml, it will be very beneficial. And also you can avoid the bubble bath therapy. Like people will be taking the tub baths. So where you can see the soapy bubbles, which will cause this type of UTIs, you can also avoid that one. And if there is any recurrence, unexplainable cases of cystitis are there, you can also go for long-term courses of the low-dose antibiotics can be taken at the night. Okay, these are all about your UTI. Then I am jumping into next topic like renal failure, which is very important one. So the renal failure as the kidney failure is formally called as a renal insufficiency. So when the kidney is unable to do its function adequately or unable to carry out its function, then we will call it like as a renal failure. So which is characterized by the reduction in the excretory and regulatory functions of the kidney. So what will be happening if the kidney functions to fail? No waste products will be eliminated from our body, and also there will be so many metabolic dysfunctionings will be happening, and imbalancing of the fluid and electrolyte imbalances will happen, and acid base disturbances also will be happening. So this renal failure can occur in an acute onset or either chronic onset. So once the renal failure occurs, if it is an acute or chronic, so if the prognosis is not good, and we can't expect even prognosis good until and unless we sometimes we have to go for the even transplantation. Let us discuss first like acute renal failure. So where acute renal failure is the sudden and complete loss of the ability of the kidneys to remove the waste. So you all knows like what is the acute onset, what is the chronic onset. So suddenly the kidney will develop. It may ranges from hours or days or weeks. So where you can see like sudden decline in the renal function. Why it will decline suddenly means like either there may be any alteration in the blood supply. Okay, you can consider it like, you can categorize into 3 types like pre-renal, intrarenal and the post-renal, which I'll be discussing later. So I'll be discussing very briefly here, like a decreased glomerular filtration rate, that is like a GFR, and increased concentration. So when you will be seeing most of the waste products in your urine, like concentration will be high, like nitrogen burn or creatinine. So the urine output is less than 400 ml per day will be there here. Then hyperkalemia. So when the blood potassium level will be normally more than the normal, and sodium retention. When the people will be consuming, much salt intake as per their daily recommended allowances. So coming to the causes of renal failure, as I told you earlier, it is categorized into 3 types, like pre-renal, intrarenal, and the post-renal. So pre-renal means like, see, if I show this one, you can better understand, I feel. So pre-renal means like, see here. So before reaching to the kidneys, like there will be any decreasing of the So there will be like marked decrease in the renal blood flow. So the before to the kidneys function, so there will be decreasing in the blood flow, which is leading to the dysfunctioning. Then intrarenal, you can consider within the kidneys any damage to the glomerulus or any of the nephrons, or reduction in the number of nephrons, losing the nephrons. So you can consider it like an intrinsic or intrarenal, which will be damaged structure within the kidney. And post-renal. So after the collection of the urine will be taken place and going to the ureter. After that, like post-renal, is there any, after vomiting, any obstruction is taken place in the outflow? That will be called as a post-renal. So coming to the risk factors, like when why it will occur most of the times, like being hospitalized, especially for the severe conditions which will be requiring intensive care, like, and also advanced ages, like vulnerable population of like aged people. Then there will be any blockages in the blood vessels, like peripheral artery diseases or leg. There will be blockages in the arms or legs, the major blood vessels which will be supplying to that particular part. Then diabetes and high blood pressures, heart failure, where the heart is unable to pump the sufficient blood to all the body parts, and it cannot able to pump to the even kidney also. There the function of the kidney will be halted. Then kidney diseases and the liver diseases. And coming to the pathophysiology of the acute renal failure, like most of the times, as I told you, it considered like a pre-renal, intrarenal, and post-renal, the causes. So it is not clear why it will be occurring, but moreover, we can consider this as like a pathophysiology, like in response to the renal injury, either any type of thing, like, pre-renal, intrarenal, or the post-renal, there will be thought to be like increasing in the intraglomerular pressure. Like, so that what will happen when the pressure is increasing, automatically the glomerulus will be like bulging, or in order to compensate, it needs to compensate. No, so for that, what it will do, it will be increasing its size. Okay, so for that, what will happen? It will be leading like a failure of the renal circulation and glomerular or tubular dysfunction. So there we can see like any, so tubular dysfunction is there. So that's why the tubules, what it will do, they cannot able to go for the selective reabsorption. So what will be happening? Sodium normally, which it cannot be conserved adequately. So what will happen? So sodium and fluid, and it also cannot able to filter. So sodium and fluid retention will be happening, which will be leading to the edema, and which is also leading to the reduced blood flow to the kidney due to the renal vasoconstriction. And you can see here, because of this, a sudden and complete loss of the kidney will be happening, and where you can see the reduced amount of the urine production, like oliguria, thereby where it is increasing like a serum creatinine, burn levels, and retention of the all other metabolic waste, like other things like burn, nitrogen, all those things. Then it will be leading to increasing the circulatory overload, where you can see like a sodium retention, which ultimately leading to the acute renal failure. So the renal failure in acute stage can see they're categorized into four phases. That is like initiation phase. By seeing name itself, or it indicates like initiation where it starts. Oliguric phase where you can see the decreased amount of production of the urine. Diuretic phase, again the kidney can restart its functioning. So you can see diuretic phase and recovery phase. So what is onset or initiation phase? Like time of the onset injury till the death of a person. So it begins with the initiation phase. Okay, so where you can see here like reducing the blood supply for the kidney. So it may, this period or this phase will be lasting from hours to days, but it can cause irreversible damage to the kidney. Then coming to the oliguric phase, like as it indicates, when there is a urine volume will be like, very less, like 30 ml to 40 ml. Sorry, here 400 written, but it is like 40. So per 24 hours. So there will be persisting decrease in the glomerular filtration rate. There you can see like a oliguric phase. Okay, so which will be lasting like a 7 to 14 days, but it will be doing a lot of damage to the membranes and the walls of the kidney. So here you can see many of the things like urea accumulation, creatinine, uric acid, and many of the potassium, magnesium accumulation you can also observe in the oliguric phase. Then coming to the diuresis phase, like it is marked by an increased urine secretion of more than 400 ml per hour. Again, it will be, kidney will be going to, first it will be starting like initiation phase, then later it will be going to the oliguric phase. Then again, it will start slowly to going back to the, functioning, regaining the function. But here you have to monitor in this phase. So because of the diuresis, patient may go into the dehydration. So you have to take care very carefully here. Then coming to the recovery phase. So it begins with the recovery of so whatever the damaged tubules or membranes are there, it will get, recover here. So like it will get stabilizes and there will be improvement in the renal function, which may be continuous for 3 to 12 months. Like it will be again to regain the function. So here like it will be categorized into like these, all the types like initial phase, oliguric phase, and diuretic phase, and the recovery phase. When you see an acute renal failure, the manifestations will be like patients may appear critically ill or lethargic, because it is like sudden onset. So the body or the equilibrium cannot able to maintain. Definitely patient looks very lethargic and critically ill. And even you can see like, very sluggish and dull and restless. He looks very fatigued. Then you can also see the decreased urine production, and dark colored urine will be there, or foamy. If you see the urine, it looks like, foamy, and it also looks like a bubble, and patient, urge to urinate during the nights, like nocturia will be there. And skin and mucous membrane will be very dry due to the dehydration. And here you can consider it as a main clinical manifestation, that is like azotemia. So where you can see the accumulation of the waste products like nitrogen based waste products. So that is called like azotemia. Then oliguria or anuria. So less than 30 ml or 30 cc, and our urine output will be there here. And also it also includes like, edema or fluid retention, which will be causing the swelling in the legs, ankles, or the feet. Here, and hypertension and rapid heart rate will be there. And here there will be imbalances even in the electrolytes, which will be causing like a metabolic acidosis. And even due to the reduction in the blood supply, so which will be leading to the anemia. And person will be very susceptible to the secondary infections also here. And there will be, like as usual, fluid and electrolyte imbalance will be there. We can also see some gastrointestinal manifestations here, like people will be experiencing with the anorexia, nausea, vomiting, diarrhea, or constipation, dry mucous membrane, abdominal pain, and they have the order of urine, like a different order of the urine will be there. And how can we evaluate this one? How can we do the evaluating of this acute renal failure? Most and foremost, we will be doing, like, in detail history collection and physical examination as usually. And apart from this, we will go with the blood investigations, which will be including, because there will be acetomia. So you have to consider, like, nitrogen products, how much extent the nitrogen products are present in the urine. So here elevated, you can go for testing of the BUN, serum creatinine level and potassium level, because person will also having the hyperkalemia. And you can, along with that, you can also see about, like, hematocrit or hemoglobin levels. And levels of the BUN and creatinine will be high when the kidney failure will be there, which is called, like, as I already told, like, where the nitrogenous products will be more. Okay. Then apart from that, you can go for further more investigations, like, urine analysis, and you can also go for some scans. Okay. So where you can see, like, any of the abnormalities. Then some imaging tests can be done, like ultrasonography or KUB, like which will be including whole structure of the kidney. And if you want to go further more investigations, you can also prefer, like, scans, renal scans, pyelographies, or the computerized tomographies. And sometimes, if it is a severe situations, or in certain situations where you can't go for the any of certain types of laboratory testings, doctors will advise you to go for the biopsy. Like, you might be knowing already, biopsy means we'll be collecting, like, a small portion of the tissue. So you may have doubt, like, how we can collect the tissue from the kidney. So there in certain situations, they will be asking you to collect the tissue. It will be sent for the identification of the abnormalities. So how they will collect means, like, they will be inserting a very thin needle through the skin, so that they will be removing a portion of the tissue, which will be tested in the laboratories. Then coming to the management, how can we manage this acute renal failure? So, since it is acute, you can go with the many pharmacological interventions, and even, like, for other alternative, like, dialysis. So here, which will be you're seeing here, there will be more damage to the kidneys. So always we have to focus on the cause. So what is leading to the acute renal failure? So based on the cause, we are going to correct it. So drugs includes, like, it will be including, we have to reduce the blood pressure, so that we are administering the antihypertensives, and we have to preserve the renal function for that, and increase the urine output. For that, we are administering here diuretics, and we can also use the low dose dopamine. Okay, so where dopamine will be facilitating here to enlarge the renal arteries, so that it will be improving the urine production. And diuretic therapies, which will be including, like, a furosemide or mannitol will be the drug of choice for this. And also you can give the calcium or glucose or insulin. Okay, so when there will be high level of potassium levels in the blood, so in order to treat that one, you can give the insulin as an antidote, so which will be given through a vein in order to decrease the potassium. So where there will be more potassium levels, in order to halt that one, you can administer this one. Then you can also administer intravenous sodium bicarbonate, as it is acting like a, to reduce the hyperkalemia. And you can also give antibiotics. Okay, so where it will, because there will be, associated infections where which will be exerted by the liver. So you can also give the antibiotics in order to treat that one. And apart from that, if any sort of seizures, if you see because of the abnormal brain cell activity, you can give even anticonvulsant drugs. Then fluid and electrolyte replacement. So intravenous solutions must be carefully selected because already a patient will be experiencing with the edema, and furthermore you should not cause any damage to the renal function. So here you will be going for the selective administration, careful administration of the intravenous solutions in order to make sure to maintain the equilibrium of fluid and the electrolyte status. Then coming to the nutritional therapy, along with the pharmacological and this electrolyte fluid imbalance, nutrition therapy is also playing a vital role in maintaining, managing the ARF. Like proper nutrition is also crucial in the management of the acute renal failure. You have to give high calorie diet, which is low in the protein, because the kidney cannot able to filter the waste products. If you give again more protein, after the protein synthesis or metabolism, the waste products, the renal is already in the deficiency or insufficiency. If you give more protein, it is unable to process it and eliminate. So that's the reason you have to give the high calorie diet, which is in the low protein. And potassium intake, you need to be restricted, that is like 40 to 60 milliequivalents per day. And sodium is also usually restricted, that is like 2 grams per day. You have to ask when you are recommending the diet for these patients with the ARF, you have to carefully monitor about the daily recommendations of the sodium and the potassium. And you can also encourage the people to take like low potassium foods, which will be including apples, cabbage, carrots, green beans, grapes, and strawberries, which will be really effective. And the alternative for this is like you can manage if you are not you can't able to manage by these things, then you can move for the dialysis. I'll be dealing dialysis with the at last in detail. Here nurses need to be focus on monitoring of the IVO charts like intake output. It is very essential, and including all the body fluids, like whatever you are administering, including your IV fluids. And you have to carefully watch the lab results and watch about the hyperkalemia symptoms. And any ECG changes are hyperglycemia or hypoglycemia, or if the person is receiving insulin infusions, you have to be monitored very carefully. And also see about the mouth care, because they will be getting the bad odor from the mouth, and also daily weights, which will be indicating the renal function. These are some nursing diagnoses I have just quoted here. And coming to the chronic renal failure, like as of now, we discussed ARF. It is like when the kidney function altered for a prolonged time, we can consider it like a chronic kidney disease. So where the loss of function in which the body is inability to maintain the metabolic and fluid electrolyte balance are getting failed, which will be resulting especially in the uremia or acetomia over a period of months or the years. That is the difference between the acute and the renal chronic kidney disease. Then it will be very slow, insidious. Sometimes the person who is experiencing chronic kidney disease, initial stages, they won't exert any of the symptoms. And when it progresses, then only the person will be exhibit some symptoms. Later it cannot be manageable. And the final stage of chronic kidney disease is called as the end-stage renal disease. So why it will happen? What will be the causative factors for this is like chronic glomerulonephritis, where you can see the inflammation of the glomerulus, and you like certain cause in cases of any infections, like long-term infections, where you can see pyelonephritis or the tuberculosis. And if you are not treating the tuberculosis for a longer time, it will be resulting into the chronic renal failure. And some sort of drugs, nephrotoxic drugs, like if the persons are receiving for a prolonged period, long term of aminoglycoside therapy, then autoimmune disorders such as SLE, like a systemic lupus erythematosus or scleroderma, any sort of autoimmune disorders, which also will be leading to the chronic kidney failure. Then any kidney stones and the infections. You can also consider people who is having the family history already, who is having the family history of the renal failure. You must consider them because they may have the chance to have this one, and diabetes or hypertension. So when there is a coming to the pathophysiology, so because of these all the factors which will be leading exerting factors or predisposing factors, so what it will cause, it will be causing the damage to the nephron. So where the nephron cannot able to function and do not recover, so where it will be resulting in decreasing in the GFR. But in order to compensate that one, nephron need to go many changes. In order to compensate the damage, it will be going to the many changes. So there it will like more concentrated blood will be there. Filtration will be altering here. So nephrons will become hypertrophy. They will increase in the size in order to maintain the in order to compensate this effect. So that there you can see urine may be containing abnormal amount of the proteins, RBCs and the WBCs, where you can also see the elevated serum creatinine, burn urea and other nitrogenous waste products, which is also known as like azotemia. Further, it will be damaging the nephron. Furthermore, like 80 to 90% of the nephrons also will be getting damaged, which will be leading to the chronic renal failure. Then here, what manifestations we can see in the chronic renal failure? Like there are several manifestations you can observe because it will be, it is like chronic. So it also includes like, you know, other whatever the adjacent structures or other systems also will be affected by this. Like if you take the neurological system, most cognitive impairments will be there, personality changes will be there, and asteriskics. So what is this asteriskics? Like, see, when the person, like if you ask the person to extend his arms like this, and from the back of, against the hands or arms, if the doctor is able to hold back or push back, the person cannot able to push back. It is flapping like this. If you push someone, it will be flapping like this. So that is called like a asterisk. This you can this will be the major symptom which you can consider in the chronic renal failure. It is a moreover like a tremor. But not the tremor. So, and also sometimes seizures will be there, and inability to concentrate and disorientation will be there, and your persons also will feel the burning sensation in the sole of the feet. And you can also consider some GI symptoms like nausea, vomiting, and food will be like, diastates, and they won't consider it doesn't look, tasty, or some ammonia ordered breath will be there. Then mouth ulcers, they frequently will have the mouth ulcers and bleeding. Then constipation or the diarrhea, and sometimes even in a severe cases, there will be bleeding from the gastrointestinal tract. And even you can persons with the chronic renal failure, you can also consider anemia because there will be erythropoietin deficiency will be there. Then pulmonary system is also including in this, like sometimes you may see, pleural effusion even because of the fluid overload. So what will be happening here? Fluid also will be accumulating in the lungs, which will be resulting in the pleural effusion. And also you can see pulmonary edema here. Then thick sputum. Then uremic pneumonitis, like inflammation of the lung tissue, and pleuritic pain, shortness of the breath. You might be seen in the clinical setup, the chronic renal failure patients, they are unable to breathe. Okay. Then if you see the cardiovascular system, since I already discussed this, there will be, accumulation will be there, fluid. So even you can see that accumulation of the fluid in the heart also, which will be leading to the pericarditis and chest pain and hypertension, pitting edema, and hyperkalemia and hyperlipidemia. If you see the skin, there will be, pruritus will be there, where consider like a generalized itching. Then the skin becomes very dry, scaly, and the hair, nails, everything will become very thin and brittle. And other symptoms, if you see generalized symptoms like, generally ill feeling will be there and fatigue. They always feel fatigue and weak, lethargic, and even urine output also will be very less, headache, and they also experience like bone pain. And there will be like, it decreased in the libido, like low level of sexual interest. And we can go for some blood investigations here, and CBC you can do, and apart from that, like RFT you can do, renal function testing, and apart from that you can go for some imaging studies also in order to find out or rule out the any blockages in the, as like a kidney stones or any structural abnormalities. And renal biopsy also can be done to rule out any of the abnormalities. How can we treat this chronic renal failure? So, like we can go with the dietary restrictions, which will be implemented in a daily recommended basis, and daily monitoring of the weight of the patient, and maintaining the fluid and electrolyte imbalances, especially. And also we are monitoring the neurological status of the patient here. And after that, like it includes like, drug therapy, so which will be including. So in order to treat the edema, we are giving here like a loop diuretics, which is including like a furosemide, so which is like Lasix, commonly known as, and also given like a cardiac glycosides, such as like a digoxin. Then you can give here like calcium carbonates or calcium acetate in order to reduce, balance with the phosphate. And antihypertensives can be administered in order to reduce like or maintain or manage the blood pressure and the edema. Then antiemetics, because since the persons also exhibit, GI symptoms, you can also give the antiemetics. And coming to the any apart from that, if you cannot able to treat, then you can further go for the dialysis, and furtherly you can go for the surgical management also, like a kidney transplantation can be done at the end stage of the renal disease. So it is like, kidney transplantation is a highly specialized procedure, and it is very sterile procedure where most of the care is not taken place, and it is a surgical procedure where the kidney is removed from one person. There will be a donor, and you can also receive the kidney from a cadaveric donor here. Like cadaveric means you can collect like a kidney from the deceased donor also. That is called like a cadaveric donor. So it will be placed into the body of a person who is suffering from the renal failure. So this is about your chronic renal failure. So here, before going to the another topic, I just want to discuss about like a little bit about care plan. So it is out of my interest, because if you know, you just ignore it. But I just want to mention here, many of the people when do write, like when I do correcting the evaluating the papers, I just come across some of the papers like, they do mention, as you people know that we are practicing evidence-based practice. So you always should write the diagnosis like, evidences, based on the evidences. And when you write in a theory part, many of the people, they do mention implementation in the theory portion. So where you doesn't have any patient, and there is, I hope you are understanding what I am saying. Like it is out of my interest, and I just want to aware of this one. Like if you know already, you have been practicing this one, you just ignore. Okay. So you need not to write implementation in the theory part, like where you can't implement that one, and you can directly write expected outcome instead of evaluation. And whatever, when it is coming to the practice purpose or clinical practice, you can write your implementation where you are really implementing the things. And one more thing, like if you are going to the assessment column, again, you need not to write any of the assessments in the planning or interventions, because once the assessment is done in the assessment column, everything like your subjective data, objective data, everything is done. Based on that, you are framing your nursing diagnosis. So I hope you understood this one. Am I clear? Then coming to the prevention, like you can ask the people to change their lifestyle or otherwise change their dietary pattern. So it will be very helpful in the prevention. And like if at all any family history is there, pre-existing renal disease is there, or in like you just ask them like adequate hydration so that they can avoid this one. And when they are taking a prolonged time of medications, you can also ask them not to go for the exposure of the nephrotoxins for a prolonged period of time. Am I clear, sir? Anyone, please respond.
Yes, ma'am.
Okay. So then I'll be discussing about the BPH, like benign prostate hyperplasia. So, like a prostatic gland is like a walnut-sized gland, which will be located in between the bladder and the penis, and which is very essential to nourish and protect the sperm here. So, what is hyperplasia? Like there will be an enlargement you can see in the prostate gland, which will be resulting in the increasing of the number of the epithelial cells or otherwise, tissue. So which it will be obstructing like, out bladder and outflow of the urine. So why it is occurring? The BPH will be occurring like most of the times you can consider it is like a idiopathic, like unknown causes. And you can also see that is, the age is the most considerable factor here, like aging along with the endocrine factors and accumulation of the dihydroxytestosterone, which you can see mostly in the age group of people. Then cancer of prostate or others includes like, obesity, inflammation, and those who are consuming the alcohol very frequently. So what is happening in BPH? Like due to etiological factors like, aging or any of other certain conditions, what it will do, it will decrease the testosterone levels. So what is happening here, the testosterone will be converting into dihydroxytestosterone. So that dihydroxytestosterone will be leading to the accumulation of the stromal cells of the prostate here. So which is further leading to the enlargement of the prostate. So when there is an enlargement, it will obstruct the urine flow. So obstruction of the urine flow will be happening, which is causing like a hyperplasia. So what are all the symptoms you can see in the BPH, like, obstructive and irritative symptoms you can observe here. That is like, person used to feel increased frequency of the urination, nocturia, like during the nights, they want to, they feel to urge the urine, and there will be like a urgency and hesitancy in starting urination. While starting urination, they feel hesitate and they feel difficulty also. And during the urination, they feel like abdominal straining. And coming to the manifestations, you can you can see the decreasing in the volume and even stream also. The stream of the urine also will be reducing here. And even when they are passing, they are unable to empty the bladder completely. There will be dribbling will be there. Like they will pass and they will stop the urination. Again, they will start. So there will be, and also urine will be involuntarily dribbles sometimes. And they feel the sensation like bladder is not completely emptied. So they always feel after even avoiding also, they feel that something else is there left in the bladder. And acute urinary retention, like when more than 60 ml of urine remains in the bladder after the urination. So even after the urination also, people will feel that still urine is remain in the bladder. And there are other symptoms you can see like anorexia, nausea, vomiting, fatigue, and epigastric symptoms. And coming to the diagnostic findings in for the BPH, you can go for in detail history and physical examination, and digital rectal examination can be done, so that you can rule out these obstructions. Then urine analysis, which will be including the culture, then serum creatinine levels, where you can see the elevated creatinine levels. And this is the specific test you can see in order to rule out the BPH. That is like PSA, that prostate specific antigen. The normal range will be like 4 nanogram per ml. When it reaches like 100 nanograms per ml or above that, you can consider the person is suffering with some prostate cancer. And any sort of like TRUS, like transrectal ultrasound also you can do, and cystourethroskopy in order to visualize the obstructions. So coming to the management, here we are doing the collaborative care. Our main goal here is to restore the bladder drainage first, like bladder need to be drain the urine completely. That means we are restoring the bladder functioning, then relieving the patient symptoms and preventing and treating the complication of the BPH. When coming to the medications, you can administer for the BPH 5-alpha reductase inhibitors, alpha adrenergic receptor blockers, or you can go with the combination of the both the things and herbal therapies. So most of the times in the BPH, than the pharmacological treatment, I feel the surgical treatments or invasive treatments are more effective. And nowadays it is more practiced also. Like if you see invasive management, like intermittent catheterization can be done, TURP, transurethral resection of the prostate gland. What they will do here, resectoscopy, they will be using here in order to, take off, and they'll be having that resectoscopy will be having the camera and which will be attached to that. So through that camera, they will be inserting into the urethra and they will be visualizing the things and resecting of the portion of the prostate tissue, so that they will be making the space for the urine to flow. Then open prostatectomy can be done, but nowadays it is not more preferable because so many advanced treatments has been emerged. Then you can also see TUVP, transurethral electrovaporization of the prostate. See, name itself, you can understand like electrovaporization. That means like they are using here like some electric cautery, so that they will be vaporizing. That means like destroying the prostate tissues here. Then transurethral incision of the prostate. And the foremost latest one now everywhere they are practicing like TUMT, that is transurethral microwave therapy. And even TUNA, like transurethral needle ablation, laser prostatectomy, intraprostatic urethral stents. Even you can go for the stents. So you can see this is the TURP, where they are introducing the resectoscopy and they are destroying the prostate tissues here. And you can also see TUMT like some sort of microwave therapy. So they are using these microwaves in order to destroy the prostate tissues. You can also see here electrocautery they are using to destroy the tissues, so that they are making or preserving the prostate functioning. Here they are using like laser prostatectomy, laser beams also they are using to destroy the prostate tissue. Even you can go for the stents in order to maintain the flow, where the people will be feeling like after the voiding also they feel like some urine is left over. So make sure to regain the function. You can also go for the urethral stents. Apart from all these invasive measures, you can also go for the dietary management, like increasing in the fruits, vegetables. You can ask them to go for some fiber-rich diets and decrease food in the fat, which will be causing constipation. Then ask them, give education about the avoidance of the caffeine consumption, alcohol like a beer, all those things. Then ask them like always they have to drink at least 50% of body water. Okay, then include the like they can also include some palmetto in the diet, like some sort of proteins they can include. Then coming to the nursing management, like they can go for health promotion, acute interventions, and ambulatory and the home care. Here you can also educate about like early detection and treatment, because if you identify the BPH earlier stage, you can able to treat that one, and you can also stop conversion of the BPH into prostate cancer. And after that, it can also focus, you should also focus like preoperative care and the postoperative care. Most of the times, what will be postoperative care includes means like, any complications are there, you have to note it down. Or after the all these invasive procedures, any sort of blood clotting in the bladder or inflow or outflow, so that you need to be monitored very strictly. Or any urethral irritation or bladder infections. So because it will again furthermore cause the complications. So in order to encounter that, you have to strictly monitor this one. And you can also advise the patient to go for some practicing of the pelvic floor exercises. And always, straining during the bowel movement need to be avoided. Can also give the ambulatory and home care, like they can well take care of their catheters, taking care of the catheters, managing the urinary incontinence, teach them how to maintain manage the urinary incontinence if they are already suffering with the urinary incontinence, and ask them, encourage the excessive fluid intake, like according to the daily intake. Then any urinary tract infections are there, you just observe them and ask them how to prevent this one. Then constipation, by promoting, high fiber rich diets, and ask them to avoid heavy liftings, weight liftings. Then refraining from the driving and intercourse. So because this will be again cause further more complications, you just better ask them to avoid those things. This is all about your BPH. Then I'll be discussing later about nephritis. So the nephritis is like inflammation of the kidney. So it can cause death if it is not treated. Like it is, you can't, even though it is a simple infection or inflammation, you can't able to neglect it. If you are not treating at the correct time, it will be leading to the life-threatening complication. So if you see the types of nephritis, like there are two types of nephritis, like acute and chronic nephritis. So if it is occurring like in an acute basis, then you can consider acute nephritis. So most commonly caused by any of the allergic reactions, like any drug reactions or any like analgesics or aspirins or cyclosporins used for any some sort of disease conditions, like autoimmune diseases or anti-cancerous drugs, or where you can also treat the depression. Then chronic nephritis, it is similarly, due to very large number of causes, which will be including like hypertension, polycystic diseases of the kidney, autoimmunity, and obstructions of the urinary tract, high blood calcium, which will be depositing in the kidney, and uric acid deposit in the kidney, which will be leading to the cadmium intoxication. So you can see how the cyst will be forming in the kidney. Like this is the normal kidney where the polycystic kidney looks like this. And there are like subtypes of nephritis, like glomerulonephritis, interstitial nephritis, hyelonephritis, lupus nephritis. That is like glomerulonephritis. It is the inflammation where you can see in the glomerulus. Then you can see interstitial means like in the tubes, like tubulointerstitial nephritis, where you can see the inflammation of the spaces between the renal tubules. Then pyelonephritis, it is the inflammation that results from UTI, which will be reaching to the upper portion, like pelvis of the kidney. Then lupus nephritis. So what is the lupus nephritis? It is the inflammation of the kidney, which is caused by the SLE, which is the autoimmune disease. So what may be the causes for nephritis? So most of the times you can consider nephritis will be resulting due to the bacteria, either bacterial infection or otherwise due to the any drug allergies, like when the kidney is exposing to the toxins. Like when any infection is happening, so antibody can attack either the kidney itself, or what it will do, it will stimulate the immune reaction so that it will be causing the nephritis. What will be the risk factors for this? So people who are having the weak immune system and who will be experiencing the prolonged throat infections, so that the bacteria will be, so you know already the throat infection can be caused by the streptococcus bacteria. So it will be reaching to the through the throat to into the bloodstream, and it can able to reach the kidneys even, and different parts of the kidneys it may damage. And wrong dietary habits, like when the people are taking high salt intake, or you know, beverages or caffeine, alcohol, so that all those things will be including here. Excessive drinking, frequent use of the painkillers. So when there is an inflammation, which will be so due to infection, bacterial infection or any drug allergies or toxins, when the kidney is exposure to some sort of toxins, so glomerulus will be getting injury here. So that what will happen? So the capillaries which is there in the glomerulus will be inflamed. So it will be resulting in the two things, like on one hand, mild proteinuria, another hand, mild hematuria will be there, and which will be leading to the accumulation of cells, which causes the blockage. So thereby, the glomerulus cannot be able to filter the blood effectively, so that waste products also cannot be filtered effectively, which will be causing the increased blood pressure, oliguria, edema, and mild azotemia. So this I already discussed, so I'm skipping this one. So what will be the clinical manifestations? Like swelling of the tissue, tiredness, cloudy urine, and it is like uremic most probably because it contains the waste products. Pus in the urine also can be seen since it is a infection and bacterial presence will be there. Weight gain, mouth ulcers, fever, and the rashes. How can you rule out this one? Like, you know, you can go for in detail history collection and physical examination, then kidney function test, kidney biopsy, and also go for the imaging studies like ultrasound, X-ray to determine any blockages or in the inflammation. How can you treat the nephritis? Like you can go with the treating of with some sort of drugs, that is corticosteroids or other immunosuppressive medications are often effective in reducing the symptoms. In case of chronic pyelonephritis, a 6 months course of antibiotics may be necessary to get rid of the infections, which will be including, you know, amoxicillin, trimethoprim, or sulfamethoxazole. And you can also treat the hypertension by the antihypertensive drugs like calcium channel blockers. So other management includes like, you know, dialysis, where you cannot able to manage the things with the pharmacological or medication, then you can go, preferably you can go for the dialysis, or at last you can go for the kidney transplantation. So this I already discussed, like there will be like a deceased donor kidney where you can consider it like a cadaveric donor. And also like there are two types can be done. One is deceased donor. The donor will be deceased, from him you can collect the kidney and you can go for the kidney transplantation. And living donor can also donate the kidney. This is all about your nephritis. Then moving to the nephrotic syndrome, which is also important. Like now the syndrome is apparent in any condition. Like nephrotic syndrome is, collectively it is having many symptoms where you can see, glomerulus will be increasing the permeability. That means it is not having a effective filtration here. So it will increase the permeability. So it will allow all the waste products. So what will be happening here? It can't keep up with the daily loss of albumin. So there will be no selective reabsorption is taken place here. So which is essential for the body also will be lost done, which will be resulting in like, hypoalbuminemia also will be resulting. So coming to the definition, like it is a clinical disorder. Nephrotic syndrome is a clinical disorder. And what are the clinical symptoms? You can see here, like it will be characterized by the proteinuria, where you can see the protein, excessive amount of the protein in the urine, and hypoalbuminemia, edema, and hyperlipidemia. So why it is occurring? This occurs due to the excessive leakage of the plasma proteins in the urine because of the increased capillary permeability of the glomerulus. So what may be the causes for this, like glomerulonephritis and diabetes mellitus, SLE, and amyloidosis of kidney, like there will be deposition of the proteins. Then sarcoidosis, cancer, trauma, infection, drugs, and renal thrombosis. If we see the pathogenicity after this disease, nephrotic syndrome, due to the all these predisposing factors, glomerulus will get damaged. So what it will do, it will be allowing all type of the waste products, like increased permeability will be happening, so that reabsorption will not take place. You can also see the huge amount of protein in the urine. That is like 3.5 grams per 24 hours need to be done, but it will be more. Then increased renal catabolism albumin, which will be leading to the hypoalbuminemia. So what it will do, it will be leading like, two hands, one on one hand, it will be like, there will be like, decreased plasma oncotic pressure. And another hand, compensatory synthesis of protein, including the lipoprotein by the liver. You see, so when there is a decreased plasma oncotic pressure here, so what will happen because of this, what it will do, it will be, so whatever the fluid is there in the blood vessels, that will be escaping into the tissues. So fluid will escape into the tissues, so that all the body parts like, arms, legs, peripheral edema will be occurring here. Where if you see here, decreased plasma volume. So when there is a plasma volume is decreasing, there will be decreasing in the filtration rate, and where it demands the increase in the aldosterone, so that it will be regulating the function, which will be leading sodium and water retention, so that you can see generalized edema, which is also known as the anasarca or dropsy. Okay. And another hand, what is happening here? The liver is trying hard to maintain the synthesis lipoproteins. So what will happen here? Decreased lipid catabolism will be happening due to the low level of the protein, which will be leading to the hyperlipidemia. And coming to the manifestations like proteinuria, you can see hypoalbuminemia and edema. Especially edema can be seen like everywhere, like periorbital edema, pitting edema, ankle edema, ascites, then pleural effusion, weight gain, hypertension can be seen. Person also will experience with the fatigue, headache, malaise, and the irritability. And the urine looks very foamy, and hematuria can also be seen, and thrombophilia, like there may be, you can see many clots can be formed. Lipiduria, even you can find the lipids. Then dyspnea and the anemia. You can see the significant manifestations here, like, so puffiness you can see around the eyes, especially in the mornings. Then pitting edema can be seen over the legs. Pleural effusion and pulmonary edema will be there, and you can see the sites like accumulation of the fluid you can see, and abdominal accumulation, then hypertension, anemia, and dyspnea. Here, erythrocyte sedimentation rate will be increasing because of these inflammatory reactions, and anorexia, fatigue, abdominal pain, and the diarrhea will be there. So how can you rule out this? Like detailed history and physical examination can be done, and 24-hour urine analysis can be done, and serum chemistry diagnostic findings need to be done. Then creatinine clearance test, then needle biopsy of the kidney. So how to manage this one? Symptomatic treatment can be done in the nephrotic syndrome. If the edema is there, you just ask them to take a rest, and proper positioning is very important. And you ask them to go for the rest, but not for a prolonged time, because it also again leads to the accumulation of the fluid. Then coming to the nutrition, just ask them like 1 gram protein per kg per day, not more than that, because if they are taking more than that, kidney cannot able to process this one and cannot able to filter and produce the waste products. And sodium restriction also can be done, and water also need to be taken in a minimally, not greater than level of diuresis. You can administer here loop diuretics like a furosemide. And hypoalbuminemia, like a moderate intake of the albumin will be very less. So you can ask them to take like a protein rich, like any animal protein. And hyperlipidemia. So you can encourage them to take low saturated fat, which is good for health, and high unsaturated fat. Then if unresponsive to nutrition therapy, then go, if you can't able to treat the hyperlipidemia, then by the diet, then you can go for the drugs like a statin. And if at all any thromboclots or thrombophilia is there, administer the heparin to rule out that. And infections are there means treat with the antibiotics. And you can also treat the hypertension by administering the ACE inhibitors to control the hypertension and to achieve better blood glucose levels. In order to treat kidney damage, you can administer corticosteroids like prednisolone, then immunosuppressants like a cyclophosphamide. If you are not treating effectively nephrotic syndrome, it will be a life-threatening condition. It will lead like infection, thromboembolic complication, and pulmonary edema, hypovolemia, growth retardation, altered drug metabolism, even ESRD. And recent research studies are showing that chlorambucil treatment is very effective in treating the nephrotic syndrome when it is combined with the prednisolone. They carried out some research studies. They given chlorambucil separately and with a randomized control trial for the 21 children. And in another hand, they given like chlorambucil combination with the prednisolone they given, and they have seen the best results. Then coming to the renal stones or renal calculi. Stones which are formed in the renal tract is called as like a renal stones or the calculi. So it is caused by because of various factors like like various substances like calcium oxalate, calcium phosphate, and uric acid increasing. So why it occurs most of the times, many of the people will be because they won't take adequate amount of the water. So it will be leading to the formation of the calculi. So what may be the causes or risk factors include like family or the personal history. If someone in the family is already having the history of kidney stones, they may have the chance to get the next generation or next people. Then dehydration. So if they are not taking adequate amount of the water each day, it will increase. Like it is not like acutely it will occur. So if you are not taking adequate amount of water in a daily basis, it will be leading definitely into the renal calculi. Because due to the weather changes also, we do lost much amount of water in the form of sweat also. Then certain diets For example, like eating diet high in the protein, and some people, they are habituated to eat, high salt intake and high sugar intake. So they also having the risk to develop this type of renal calculi. Then obesity. If they are not maintaining the proper BMI and large waist size or otherwise weight gain, will be having the risk to develop renal calculi. And any sort of some digestive factors. If the people are not having good digestion system and they have any defects in the defects with the bowel diseases like inflammatory bowel disease or Crohn's disease. In such cases also, people are having the chances to develop this renal calculi, and some sort of medical conditions also resulting in the renal calculi, such as, like, if you consider tubular acidosis or cystinuria or hyperparathyroidism, which will be some sort of conditions where you can also consider like a renal calculi. And certain supplements and medications, such as, vitamin supplements or some sort of laxatives, those people can use for a prolonged period of time, like antacids, or people will be using the medications for treating the migration, depression. They may also cause, if they are using for a prolonged period of time, they may also cause the risk to develop the renal stones. So there are, types of different types of stones are there, like calcium stones. So which will be including this is the most common kidney stone, which it is formed by the calcium oxalate. So struvite stones are, and you can also see most probably struvite stones when the people are having the UTI. But these stones can grow very quickly and become quite larger, sometimes with few symptoms or little warning. Then uric acid stones. So it will be resulting because of too much of fluid and too much like uric acid will be accumulated. Because of that, it will be resulting. Then cystine stones, like these stones will be like hereditary sometimes, like which will be causing the kidney to excrete too much of specific amino acid. You can see so many areas where calculi can be located in the kidney. Kidney stones you can feel in the major and minor calyces and even in the ureter, where you can see there will be obstruction in the flow of the urine. So what is happening here? Supersaturation of the urine. What is supersaturation? Like it will be including most of the waste products in the urine. So many waste products are there in the urine. The urine, it cannot able to filter it. So it will cause the fluid loss and dehydration. Because of the fluid loss and dehydration, so because of that, what will happen? Urine become very strong, thick, and supersaturation. So that will be causing so when it becomes supersaturation, it can't able to filter. That's why it will form the crystals, which will be precipitating and unite, which will be causing the formation of the stones. So most of the times you can see renal calculi in the males when comparatively females. And what symptoms you can see means when the size of the stone is increasing, like it will be radiating to the flank area. And also they feel like back pain, bone pain will be there, hematuria when they voiding. During the voiding, they feel hematuria and they feel very sharp and sudden and severe pain. Okay, when the stone is moving, so it will cause the much pain. So you can see here like very severe and short pain will be there, especially back and below the ribs. And the pain will be radiating from the lower abdomen and to the lower abdomen and the groin also. So the pain will be, it will come with a wavy type of pain, you can see, and it fluctuates. Like sometimes it will be very sharp, sometimes it will be very dull. So even while urinating, people will feel the burning sensation. And other symptoms include like, urine will become pink, red, or brown in the color. Then cloudy or foul smelling urine can be seen. And they feel, persistent need. Always you need to urinate. They feel clients need or people needs to urge to urinate. Urinating more often than usual or urinating in small amounts. Even though they urinate very frequently, but whenever they urinate, they will urinate only small amounts. They feel that again, like, something they'll be storing in the bladder like that. Then nausea and vomiting also can be seen. Fever and chills if an infection is present. So how can you rule out this one? Like, how can you diagnose? Like, in detail, history and physical examination can be done, and blood test can be done in order to check like calcium levels and uric acid levels. Because if the calcium and uric acid levels are increasing in the blood, then only it cannot able to filter, urine become, super saturated. And here, urine test can be done to know about the proper functioning of the kidney and the infections. Then other radio imaging tests can be done like X-ray, MRI, ultrasonography, etc. How can you treat this one? Like hydrochlorothiazide to prevent the calcium stones resorption in the calcium retaining in the renal tubules. Then allopurinol can be the drug of choice to prevent the uric acid calculi. And you can also administer sodium bicarbonate or sodium citrate to maintain the pH, urine pH. And alpha penicillamine and thiopronin to prevent the infections. And coming to the surgical management, here you can also go for the cystolithoplexy or cystoscopic lithotripsy or percutaneous nephrolithotomy. So lithotripsy is, you might be heard about the ESWL, that is like extracorporeal shock wave lithotripsy. So what they are doing here, they are using some sound waves to create the strong vibrations or shock waves, so that by using these shock waves, they are breaking the stones into tiny pieces so that it will be eliminating when they are passing the urine. Okay, so this procedure will be lasting like, 45 to 60 minutes, which will be causing the moderate pain. But it can be done under sedation or light anesthesia to make the patient comfortable. But if the stone is too large, then they can go for further, endourological and lithotripsy procedures. Failure to remove, then they can go for the open surgical procedures like ureterolithotomy. This is one surgical removal of the calculus from the ureter through a flank incision. They will be doing the incision and removing the stones. Or otherwise, you can also see other procedures also can be done like pyelolithotomy or nephrectomy or the things. Like you can see here in the image, they can do even like a suprapubic incision, which will be used to, stones cannot be crushed. Then they like a extracorporeal wave lithotripsy, you can see some shock waves we are using to grind the stones. Here it is not possible in certain cases. So here they will be choosing this type of procedure like suprapubic incision they will be done, and they will be removing transuretrally the stones. And if at all, in rare cases, sometimes they will be going for pyelolithotomy or nephrolithotomy if the stones formed in the renal pelvis and the renal calyces. And very rarely, if these are all not working out, then they will go for the total nephrectomy. Okay, because of the kidney damage or overwhelming the renal function or any sort of abdominal renal parenchyma, which can be responsible for the stone formation. Then you can also see here uteroscopy. Uteroscopy is also maybe used for the to treat lower urinary tract stones. So these are all the procedures we can do to treat the renal stones or renal calculi. Then apart from that, you can also focus like a nutritional management, like you can encourage the patient to take adequate amount of water, like more than 3 liters per day. And you just instruct them not to go for or limit the limitation of the caffeine or coffee or tea, and ask them to avoid these things, and limiting the oxalate rich foods, that is like dark rough phase food, spinach and cabbages, tomatoes, chocolates, tea, coffee, and limiting the purine and calcium rich foods, that is shellfish, liver, kidney, meat, chicken, mutton, pork, beef, milk, cheese, ice creams. By this you can treat the renal calculi, and you can also educate them, go for the lifestyle changes so that they can better prevent the renal calculi. Like as I told just before, you can encourage them go for the taking in adequate amount of water throughout the day, which will be resulting in the prevention of the renal formation of stone formation. Then you can ask them to go for include their diet or improvise their diet, which will be restricting the oxalates. Okay. Then also choose a diet which is low in salt and animal protein. So you can also educate the patient about the DASH, like dietary approaches to stop the hypertension. DASH diet also you can encourage them to teach. So you can encourage them to ask them to, like, calcium in the food doesn't have any effect your risk for the kidney stones. So continue eating the calcium rich foods. And if you are not treating the renal calculi, it will be leading some of the complications, like it will infections and sepsis or obstruction of the urinary tract. Obviously, obstruction will be there. Hydronephrosis, then hydroureter, renal failure, renal hematoma, and the hypertension. So these are all the things you can do in order to treat the renal calculi. And at last, I just want to discuss dialysis. So the dialysis is the procedure used to correct the fluid and electrolyte imbalance. You might be knowing, like, it is when the kidney is unable to do its function, we are doing this is the equipment which the kidney artificially by the dialysis to remove the waste products in the renal failure. What dialysis can do and what cannot. So what it will do remove the waste, waste removal of the and fluid removal only can be done by the dialyzer. It cannot correct the endocrine function of the kidney. So because already the endocrine function of the kidney is affected, so that only we are doing the work. Endocrine function cannot restore. We cannot restore the endocrine function. Only we can, the dialysis can be done to remove the waste products and the fluid from the body. So it is, hence we can consider dialysis is not a cure for the kidney failure. It is like a treatment. So when coming to the dialysis, there are like two types of dialysis, hemodialysis and the peritoneal dialysis. You can see the picture. Hemodialysis is, hemo simply means that blood, where dialysis. So what we are here removes the nitrogenous waste products, excess fluid and electrolyte from the body, from the blood by means of artificial kidney. It acts like an artificial kidney. Okay. So 90%, nearly 90% of all dialysis patients receive the hemodialysis. And peritoneal dialysis, it removes the nitrogenous waste products, excess fluids and electrolytes from the blood by means of peritoneal membrane. You can see in the image. By means of peritoneal membrane. It is very rare, and approximately only 10 to 15 patients are receiving the peritoneal dialysis. So how does long dialysis take? Hemodialysis usually is done 3 times a week. Each treatment will be lasting from 2 to 4 hours. During the treatment, patient can read, write, speak, talk, or watch the TV. You might be visited during your clinical posting dialysis units. How dialysis will be occurring? So this is the dialyzer, hemodialyzer machine. And so first the blood will be whatever which includes the waste products will be sending to the dialyzer. Their purification can be done. Again, it will be filtering, blood will be returning to the body. And this is the dialyzer. You can even see the blood vessels, which indicates like a blood vessels of artery and vein. So dialyzer is, moreover, you can consider dialyzer like a artificial kidney. So whatever the function is done by the kidney is here carried out by the dialyzer. So it will be exchanging the waste of the blood through the dialysate, which will be like a semi-permeable membranes of the tubule. Okay, you can see here. So how the blood will be in and blood will be out. How the dialysate will be in and out. Effluent will be in and out. So majorly the dialysis will be, functioning based on the three principles. That is like osmosis, diffusion, and the ultrafiltration. So what is the diffusion? Like movements of the solutes from an area of the greater concentration to an area of the lower concentration. So what is happening here in the renal failure? So there is like, increased amount of the waste products like a creatinine, uric acid, electrolytes will be there. So what is happening here? Due to the diffusion, this will be sent to the dialyzer. Okay, this will be sent to the dialyzer. But unfortunately here, the WBC, RBC cannot be sent because they are too large to diffuse. Okay. Then coming to the osmosis, the movement of the fluid from an area lesser to an area of greater concentration of the solutes. So here what is happening? Whatever the like a glucose which will be added to the dialysing agent, what we are doing here, we are creating a high concentration in the dialyzer so that even blood can able to move into that. Then at last, ultrafiltration can be done. So what is ultrafiltration? Like ultrafiltration is, it is mainly defined as like, water moving under high pressure to an area of the low pressure. Okay. So negative pressure will be done to suctioning force to be dialysing membranes. Sorry. So how to do the vascular access of hemodialysis here? So access to the patient's vascular system must be established to allow the blood to be removed, cleansed, and returned. So that is the major goal in the dialysis. Like we are taking out and we are cleansing the waste products, and again we are returning through the patient's vascular system. But in order to do the dialysis, we need to have several types of access should be available, like fistula, graft. Okay, so majorly we are using like a fistula and the graft. So the you can see here, and even what is by to a vein. Either they will be artery and the vein, either side by side or into a. Once they it time before you start dialysis, it at least to mature, it use and segment of to dilate. Effectively can be done. In order to what you can ask the patient, you can to perform exercises to increase the vessel. Like might be seen as you all can be given to the patient so that they will be pressing that so that the fistula segment will be dilating. Then the other one is like, a graft. So arteriovenous graft can be created when the fistula is not working out, then they can go for the grafting. Okay. So how they can do the grafting? Like they can be do subcutaneously. In the subcutaneous, what they will do, inserting either biological or biological Okay, with artery and the, so they will be attaching both the things and making a graft. So when you can go for the graft, why already fistula we are using? Why we are going for the graft means like the people for the patient not able for the creation of, then go for the graft arms and the upper thumb, upper thigh. You can see it here.
Hello? Excuse me, ma'am? Ma'am, you are not audible. I think there is some network issue. Ma'am will join soon. Kindly wait.
Hello.
Yes, ma'am.
Sorry for the interruption, some network
Okay.
issues.
Yes, ma'am. Okay, ma'am.
So it is the peritoneal dialysis is like, it is a very, as I told, it is a rare. It involves like a repeated cycles of instilling dialyzing solution into the peritoneal cavity through a catheter into it. You can see in the image. So the PD system will be insulting, and to the connector, they will be introducing the peritoneal dialysis solution here. And this peritoneal dialysis, a patient can take in the even home setup also if they are comfortable. Like, they can go for a continuous ambulatory peritoneal dialysis, which can happen throughout the day at work or at home, while the person even doing their daily life also. And if the patient don't want to go for that, even they can go for APD, like automated peritoneal dialysis, in which a dialysate solution is changed by the machine at night when you are asleep. So the machine will exchange 8 to 12 liters over 8 to 10 hours. So when the hemodialysis is indicated and peritoneal dialysis indicated means like when the fluid overload is not responding to the diuretics. If you are giving diuretics, still it is not responding, then you can go for the hemodialysis or any type of convulsions, uremic convulsions especially, or in case of pericarditis, pericardial effusion, if can't able to treat with the medications like ARF, CRF. Whereas in the peritoneal dialysis, when the hemodialysis is not possible due to the vascular access or infants especially or small children, then you can go for the peritoneal dialysis. And here you have to take a consent, like patient willingness need to be there, and motivation and ability to perform dialysis at the home. There are some complications also will be there if you can't able to maintain this properly. Like sometimes when you see after the dialysis, so many patients will feel very drowsy. And during the dialysis, monitoring of blood pressure is very essential. And here you can see hypotension, muscle cramps, and clot formation, septicemia, hepatitis, and disequilibrium syndromes can be seen. Where if you see the peritoneal dialysis, So exit site infection may occur because it will be installed directly into the peritoneum. So there may be chances for peritonitis again. So if you are not able to maintain this peritoneal dialysis, again, it will be leading like, peritonitis, which will be causing the life-threatening condition. Also, there may be chances for, formation of hernia, low back pain and protein loss. Sometimes it may lead to atelectasis and the pneumonia. So what care you have to give to the patient while going for the dialysis? Informed consent. You have to better explain the things very well. Ask the patient to void and check the vital signs beginning and last. Every 30 minutes you have to monitor. And before going to the dialysis, you just check cannula and fistula for the patency. You just have to palpate and feel the thrill and auscultation of any brutes are there, or any like you can withhold the hypertensive on the day of hemodialysis, and you have to give assurity for them. And during the dialysis, you can regular observation can be done. Check the vital signs for record vital signs every 15 minutes, and you can also serve the food as per patient interest. And like if they are hypotensive, they should not be in the prone position. Then each treatment will be last for 2 to 4 hours. So they can allow all these things, activities can be done. You can also give them diversional therapy. And during the dialysis, if any complications are arising, you can immediately inform to the doctor. Then after the dialysis, check for the vital signs again, and urine output, or what about urine flow rate, everything you have to monitor and record it for the documentation, and also to monitor the status of the patient. Then explain about the necessary care which is need to be taken at the home even, and educate about the family also about the dialysis. These are all the care you can take before and after and during the dialysis. So by this, I just wind up my session. Like I hope I covered all the topics which are very necessary in the renal disorders. Hello.
Yes, ma'am.
Hello. Yes,
Yes,
ma'am.
ma'am.
So by this, I can wind up my session so that I feel that I have covered all the topics, which is like including in the renal disorders mostly.
Okay, ma'am. So thank you so much, ma'am, for the wonderful session. So good afternoon to one and all present here. As we wrap up the first session of day 10, it is my privilege to sincerely thank our speaker, Mrs. K. Jyotishri ma'am, for such a valuable and engaging session. Your way of explaining the topic was not only informative but also very easy to follow. The insight you shared really helped deeper our understanding of renal disorder, and I'm sure everyone here learned something they will take back with them. Thank you, ma'am, for taking your valuable time to be with us today. A big thank to our participant for showing up. Thank you, all the faculties, students, and the organizers. Let us now look forward to the upcoming session of the day with the same spirit of learning. I once again thank and invite you all to join us back at 2 p.m. for the next section. Thank you, ma'am. Thank you
Okay,
so
thank
much,
you.
ma'am, for the wonderful session. It is amazing. I hope they understand well.
Yes, ma'am. Thank you so much. And I just want to, appreciate and give my congratulations to even Deepthi ma'am for organizing such an wonderful sessions. It is an opportunity not only for the, participants, even for the speakers as well, and also all the organizing committee. I convey my, greetings, and thank you so much for having me today.
Thank you so much, ma'am. Thank you.
Thank you.
We will start next session.
Participants, we will meet at 2 p.m. for the next session.
Kindly.
Kindly